You're listening to
CRST
the podcast.
from Bryn Mawr Communications.
We're back with Dr. Goel and Dr. Lin for part 2 of the KLEx study review.
So we've talked about indications, we talked about surgical planning and technique leading up to the nomogram. And I want to move into intraoperative complications and how to avoid them. Before we get into specific issues that can occur, I want to get your perspective, gentlemen, on how you guys prepare the eye routinely for your patients to avoid these complications. I think that's the number one thing, right? And I'll throw out one pearl, and I want you guys to all please pick one that you like as well. For me, I meticulously dry the fornix. I want to make sure there's no fluid there. I'm getting amazing suction. When I have the ring on, I see the white opacity all the way around. There's no bubbles or fluid anywhere. That tells me I have solid suction, and I'm less likely to have, breaking, having a suction loss and that kind of thing. What is one pearl or two pearls you recommend to beginning surgeons?
The first is actually patient counseling. We actually have a video of what they're supposed to be looking at, the screen blinking light, what they're not supposed to do, which is to follow the green light. So then we have them see the video, we show them the green light moving around, and they're supposed to look right past it. And that's been very helpful. And then I take a pen, or we have our technicians show a pen, and we have them look at the tip of the pen, and we move the pen around and show them that they're not supposed to follow that tip.
That's interesting.
What I've found is the number one reason we lose suction, besides the other problems that we can talk, if the patient is confused and wants to follow the light while it's moving. The green light is moving around because they're moving their eyes, right? So it's like the dog chasing their tail. It just keeps getting worse, and then they lose suction. So we found that to be very, very helpful. And that's the first step, is that counseling. And then
I love that.
We count it down during the procedure, especially when you're using the 500, it takes 25 to 30 seconds, right?
Like an eternity.
Yes. And especially if you're using some asymmetric, changing the parameters and things, it can get up to 32 seconds. So the 800 is definitely advantageous for that, reducing the time where you could lose suction. But I think the patient counts is important, and then drawing the fornix is the cul-de-sac, as you mentioned. And then also the drops, I do feel like you have to put some people say, well, we'll just put one drop of anesthetic, and because we don't want to, cause any problem with the epithelium. But I found that one drop is not enough. I feel like I need to put 3 drops, but I don't put the drops in. I don't let the technicians put the drops in. Put the drops in right before I'm going to do the procedure. And then obviously, within 10 seconds it works. And then we start the procedure. I wouldn't put the drops in a long time, like, 20 minutes before, and have technicians put that in, because that's going to cause more irritation. And then we don't really prep the eyes with betadine or anything like that. I think less is more for small, and it's, infection rates pretty much non-existent with that small incision. So that's sort of our protocol, is to really not touch the cornea. One pearl is when you move to, you could visualize the eyeball on the scope, right, before you dock. I think that's really good practice, to look at that cornea before you start docking. First, you can see where the visual axis or green reflex is. You can see the white reflex. Okay. So we have a map of where we think the reflex is. And then now I visually look at it using the white fixation light under the microscope, which is correlates pretty well with that, as another test to make sure, they weren't looking at the wrong place with the topography. And then at that time, this is a good time to look at the cornea to see if you have a lot of debris, or if there's a lot of any sort of problems that are on there. And then you can kind of wipe it off with a wet sponge at that time. And then after I wipe it, then I move the patient to dock position and then dock. So that's how we sort of do it, protocol.
That's really interesting. And then do you drape the lashes to keep the meibomian secretions out? Okay.
Yes, I always drape the top lash, not the bottom one.
Okay.
Secretions.
So Robert, let's talk about some intraoperative complications that new surgeons especially can face. I remember when I first got started back in 2020. I'm a very experienced LASIK surgeon. I've done over 100,000 procedures at that point. Now I'm going to start a new procedure called Smile, and I need to learn how to dissect out this lenticule from within the cornea. Now, I also do cataract surgery, so I do have the skill set to be doing microsurgery and fulcruming at the window, those kinds of things. But I just didn't have a great handle on the dissection technique, right? And so what pearls would you have for beginning surgeons who are having to deal with difficult dissections, wrong plane dissections, difficult lenticle removals, bring about tearing of the incision at the top, or even a cap perforation? And we don't have to take them all at one time. And I think probably your pearls will relate to all of them. Like, what would you say to surgeons who are starting out and how to avoid some of these issues?
Well, I think first it's the mindset. So you have to kind of go in there with the right mindset that this is a new procedure. And even though you're very good with your hands and good with these other procedures, you have to first practice on some pig eyes and do like 50 of them or 100 of them and really try to figure out, like how to get that hand position and just how you do the dissection before your first case. Then on your first case, I think a lot of the difficult dissections come with the laser. It's a laser issue or it's a corneal, tear film issue, right? So, or debris issue. So if your laser doesn't have the right energy setting, it's not calibrated properly, or if you have a rough epithelium or you got a lot of debris, meibomian secretions, you're going to have a difficult time. I would also,
Yeah, how would you know? I'm sorry to interject, but how would you know if the energy setting wasn't good, wasn't optimized?
yeah, well, that's what, your Zeiss service person would be sort of in tune with that. And there's some standard settings that we'll recommend, but that's usually not the biggest problem. Now, the environment of the laser has to be good too, right? It can't be too hot, too cold, too humid and all that. But assuming the laser is performing well, you have to make sure you control the patient elements. Let's say you don't have any dark spots or anything like that. That's different animal. But let's say you think it's a good dissection. It's a good laser ablation pattern without any dark spots. When you first go in, then my feeling is you need to fixate the eye. So
I agree with you 100%.
with the forceps.
Yes.
Because patients could be moving around. And it's very important to define the anterior posterior plane without any sort of like you can't be confused in the middle of a procedure. Is it anterior or posterior? You need to be really intentional that you're in the right plane. It's the anterior or posterior. And that's really, really helpful. Then I actually like the newer thinking of which, I wasn't doing until more recently, but it's to actually dissect the anterior plane with this one tunnel up there. And then you were alluding to that really helps with the lower myopia cases. But in let's say the first 10 cases that you do, or the first 20 cases, the surgeon that's beginning should really focus on patients that have a prescription of -4 to -6. If you go with a -2, you're just asking for trouble because it's difficult. It's like learning cataract. You don't want to start doing, a dense white at the beginning.
Right. That's right.
So yeah, it's patient selection, finding the right starting patients. I think that's important. And you got to find a patient that, is cooperative, right? Not someone who's very on edge and you could tell if they're moving their eyes around a lot, in some other testing that you do. So I think it's patient selection, because what's going to happen is, unfortunately, a lot of surgeons, we don't do all these things. And when they end up doing their first 5 or 10, it's hard to even get those patients. You choose suboptimal patients and then you get a bad result. And then you're like, well, the Smile is terrible, right?
Right.
I'm going to go
That's
back to
right.
LASIK, which was easy. And then
Right.
that's what happens. So we need to kind of, you made a huge investment in the Smile laser. So let's make sure you do everything to make sure that it's going to get the results that we know you can get, because there's a lot of experienced people that are, there's 12 million procedures performed in the world already, right? So
Yes.
obviously it's a great procedure, but there is a learning curve. So that's what I would say.
I agree with everything you just said. I've even suggested to new surgeons to have the Zeiss trainer out there, not just for a day or two, I had the Zeiss trainer with me for my first 50 cases, even though I was, certified after 10, because I was constantly learning from them different techniques, different ways to doing things. And they were also able to observe my laser ablation pattern and call the engineer up if it's something that they didn't like that I wouldn't know any better about. And it's only when I got my second laser that I realized how difficult my first laser was, because I didn't realize what an easy dissection was supposed to be. I just thought all dissections were kind of sticky. And then I got my second laser and the dissections were super easy. I'm like, well, why can't we do this with the first laser? And then I had the engineer come back in and they tweak something, and then it's been better ever since. And so I think that there's some of that as well. Like, we don't know what we don't know. So to your point, if the laser's in a good temperature humidity situation, you've got that knocked out, you have good energy settings, you have good spot sizing, and you have a great laser treatment, then it comes down to the dissection. And I 100% agree with you that using my second hand to stabilize the globe is so critically important. I know a lot of experienced surgeons don't feel like they need to do that anymore, but I do recommend that for definitely, newer surgeons. And I still do it after like 6,000 cases. I still do it because I find I have better control. And I do like the two tunnel technique that you alluded to, like make the anterior tunnel, but then do the posterior separation first, because I think that's the stickier one. And to be able to knock that out by having counter traction above it is much better than doing that second and then not having the counter traction for sticky ablations. I agree with everything you said. The one thing that we don't have to worry about again in the US is having caps that are too thin, because we can't adjust the cap to let anything other than 120 microns. So that'll keep you out of having a problem of, going through a cap and having a cap perforation.
Well, I was going to say another pearl is really when I was starting to do the cases, I wanted to know, like, because I was trying to compare it to LASIK, right? I'm like, well,
Yeah.
why patient not 20/20 the next day?
Yes.
So I'd go back and I probably looked at hundreds of my own videos to see what did I do differently? Did I go into the visual axis? Did I do this and that? How was I holding the instrument? Because I was trying to get every patient to be 20/20, right?
Mm.
Because I wanted to be comparable to LASIK. And I think with the lower energy settings, with good technique, you can get pretty close to, what you're getting with LASIK on day one and with the dry eyes. And definitely in a few days, it's the same as LASIK in terms of visual quality. And if you kind of average with the dry eye LASIK cases that bring down the uncorrected vision compared to the small cases that may be a little fuzzy 20/20 or something, I think overall the small patients are still much happier. But I think, if you have a hard dissection and then you're going to have some suboptimal results, but you'll get there once you get the good dissections and, it doesn't take that long to do the procedure. In fact, for once you become experienced, it's crazy. It takes me almost twice as long to do a LASIK procedure as a small procedure. So if I'm doing
Absolutely.
small procedures, I'm like, oh yeah, this is going to be an easy day. And if it's the same number of LASIK patients, I'm like, it's going to be a long day.
No, I agree with you. It's funny because when I have the residents watch me, and they'll watch me in my one office where I have a 500, and they'll come the next day when I have the 800. They're just like, this is so much faster. Holy smokes, I'm getting through these eyes like so quick. And it's fun. It's fun for me. It's fun for the staff. It's fun for the patient. They're amazed at how fast it is. And because the 800 isn't just fast, I think it delivers a much better laser ablation, which affords us to have a better dissection, which leads to better visual outcomes, right? So it all kind of flows in together. So, I know we're getting to kind of the end of the podcast here. Do you have any final thoughts you wanted to share with everybody as we talk about overcoming smile intraoperative challenges for the newbie smile surgeon?
I think in terms of the intraoperative complications, you alluded to if you have a difficult dissection, right, then what can you do? And, and I think there's a whole podcast on, dark spots and like that. But what
Yeah.
I've noticed, it's like most of the dark spots are okay, especially if it's sub-threshold energy. The ones that cause a problem is when you have actually meibomium secretions that are really blocking a large portion of the center. And if you get that, then that's when you might not want to dissect that one and kind of convert that to stop and then convert to LASIK. But all the other ones, I've been surprised. I always thought in that area where there's really no white area, no bubble pattern, I feel like it's gonna be a really hard dissection, but it's dissected pretty smoothly through there. Like it was like full bubble pattern. So
Yes.
I think that's one thing where before I was more scared that, oh my
Mhm.
God, this happened and all that. But the reality is most of these, they turn out well, in terms of the dissection. They didn't affect it at all. So that's one thing that I noticed. In terms of if you don't know which plane you're in, that's a problem.
Mhm.
And with the 800, it is easier to define the anterior and posterior lenticular planes. For some reason, the 500, it's much more difficult to get into
Mhm.
the anterior plane. It has something to do with the side cut or the energy level or something, but it's more difficult. With the 800, it's pretty easy to get into the anterior and posterior plane. But define the
Mhm.
plane, and I would say that when you're doing the anterior plane, you don't want to tent it up too much, but you have to know that you're in the anterior plane. So you kind of
Mhm.
push your instrument kind of more anteriorly, right? And whereas
Mhm.
the posterior, especially if it's like a thin lenticle, you want to go more posterior, right? Just know you're in
Mhm.
the posterior. So you don't want to go
Mhm.
up and tear the lenticle. So that's why it's important to know which plane you're in and kind of
Mhm.
make that sort of motion. And then it's important to go all the way to the periphery, of course. You don't want
Mhm.
to truncate that, especially if it's a thinner lenticle, although it makes less difference if you truncate a very thin, small ablation because there's not much tissue there. But it's
Mhm.
pretty hard to retain a lenticle in the center. What you'll find is a little bit of retained lenticle in the periphery, which probably won't affect the visual outcome at all.
Mhm.
Eh, if you're not that experienced, I wouldn't go in there trying to dissect that off the wall and all that, because then you might tear the cap and cause a lot of edema and cause a lot of irregularities and irregular astigmatism as well.
Mhm.
So anyway, those would be my pearls.
Yeah, those are excellent. I mean, that a lot of that comes from experience, right? That you have and you can share with others. And in addition to that, what I'd say to surgeons that if you have a difficult dissection, you're having trouble removing a lenticule, sometimes just don't remove it. Leave it intact for the day and come back a different day and reassess and see where you are. Many times, just taking an extra day or two to kind of collect your thoughts and examine the patient of the slit lamp or do an OCT and kind of get a better sense of where you are will help you to better manage that. I had one patient I'll just share where I had a difficult dissection of the very thin ablation and ended up just converting the cap into a flap. And then I did a direct visualization. I just peeled off the lenticle from the cornea and put the flap back down like a lacy flap, and he did great. So we could do things like that to get out of sticky situations.
Yeah.
But
One pearl would be if you're doing the laser does the posterior ablation first, posterior part of the lenticle first. So if in that one you have a very large dark spot or something that you don't feel comfortable, it's best to stop right there and immediately stop and then just convert to LASIK. Because once you start making the anterior lenticle, then
cap.
you have the cap, right? Then you have less room. And then
Mhm.
ultimately, if you make the side cut also, that can get you into problems because then you can get air, oxygen that's going into the side cut incision. And then when you make the flap, it could be more difficult, or sometimes the flap doesn't come out the way you expect. You'll have dark spots in the flap. So the key is if you know you're going to abort, try to abort at the posterior lenticule bubble pattern first. And then in the worst case, in the anterior one, but don't do it. If you do it after the side cut incision, then you should wait a day before you do the LASIK flap.
That's a great pearl, because otherwise you'll have vertical gas breakthrough in that area and
Right.
not be able to finish the flap to your point.
Right.
Well, I want to thank everybody for joining us today on the CRC podcast of overcoming smile intraoperative challenges. I want to thank the other panelists, Doctors John Dunn and Robert Lin. This is Sonny Goel. I hope you guys enjoyed this and learned something. Thank you.
Thank you.